Hello, everyone, and welcome back. I'm Joe Chappelle, and you're listening to the OBGYN podcast. Today, we're going to do something a little bit different, hopefully the start of a monthly series of journal clubs. Every month, we'll be choosing an article that is free online, so everyone can read it. And this means that likely we'll be choosing articles from either the Green Journal, the Gray Journal, or even the New England Journal of Medicine. That being said, if you have a great article that you want to see reviewed, please send it my way, and we'll put it on the show. Today I want to introduce my co-host for this episode, and hopefully a lot more to come. His name is Jerry Ballas. He is an MFM at Baylor University, and I am very happy to have him here.
I'm going to correct you there, Joe. It's Baylor College of Medicine. Baylor University is in Waco, and we don't go there.
Okay, so there you go, Baylor College of Medicine. I apologize to all the Baylor people out there. In any case, let's get started today. I chose an article from the Green Journal, the April 2017 issue. It was written by Mohammed Mer, and it was from Manufia University in Egypt. The title is Sildenafil Citrate Therapy for Oligohydramnios. So the way we're going to structure this is we'll start out with some opening remarks, and then we'll start the intro, go through the paper, and then we'll circle back to the abstract. A link to the paper is in the show notes, so you can either read it ahead of time, follow along, or just sit back and listen as we go through it, whatever works for you. So to start off, Dr. Ballas, do you have any opening thoughts on this paper?
So I got to say, when I saw the original content or the original theme of the paper in terms of dealing with oligohydramnios as an MFM, we're always trying to find ways to deal with the placenta, which is a big mystery to us. The use of vasodilators like sildenafil isn't a new concept. A lot of us have been looking at whether we can help with growth restriction or other problems that we assume are due to lack of blood flow or lack of uteroplacental insufficiency. So looking at something like sildenafil to deal with potential uteroplacental insufficiency is an area of interest in most MFMs.
Yeah, I mean, I have to agree. When, first thing I do when I look at a paper is say, does this apply to me? Is it interesting? And I would say certainly oligohydramnios is something that we see in clinical practice on a regular basis. So it's certainly of clinical interest.
Correct. And, they're attacking a very specific offset of oligohydramnios, the idiopathic oligo. Typically when we think of oligohydramnios, we'll look to see any other abnormalities, whether it's fetal growth restriction, whether there's Doppler abnormalities, uterine abnormalities, some sort of secondary cause. But one of the most frustrating things is when you have that idiopathic variety that you can't quite put in the back burner, but at the same time, at some, say, 32 weeks, you're not really going to act upon. So this is definitely an interesting study population that I give them credit for.
Yeah, I couldn't agree more with everything you just said there. I mean, that idiopathic oligohydramnios, and I think this has become important in this paper, is a very challenging one, especially when you're extremely preterm, because, when you get to 38 weeks, fine, deliver, but at 30 weeks, what do you do? How long do you watch them? Can you do anything for it? So I definitely appreciated the gist of this article. All right, so why don't we move into the intro? And one of the first things that I like to think about, or I like to organize it when I go through this, is a couple of questions, which is, what are we talking about? Why is it important? Is there any background I need to understand about the question being asked? And then most importantly, what question is being asked? And so I'm going to try to go through it with those kind of things in mind. So some of this journal club is about the actual research, and we're going to talk a whole lot about their methods and inclusion, exclusion, how they analyze it. But another part of journal club to me is the art of scientific literature, and how do you write a paper, and how do you convey your thoughts to other people. So sometimes I might go a little bit into the weeds on that, so I apologize, but that's the stuff that fascinates me. So in the first one, I think that we've already kind of just, determined and said what they're studying, which is the, pathophysiology of oligohydramnios and what can we do about it besides just watch it. Next part is, why is it important? And this, they don't do such a good job of saying why oligohydramnios is important. I don't know, what do you think, Jerry?
Yeah, no, I think they they kind of kept it a little light on the background. As an MFM, kind of just day to day, I know the importance of fluid level in terms of telling me a little bit about placental function, fetal renal function, fetal well-being. We use it part of our biophysical profile, so it's almost second nature to me to know that a fluid level check is almost like a vital sign to the pregnancy and to the fetus and the uterus, and even maternal status as well.
Yeah, I mean, absolutely. I mean, I think in some ways, the readers of the Green Journal probably know exactly what you just said. Mm-hmm. But when you're trying to make a case for an intervention on something, it would be nice to say why it's bad and therefore why you think it's important that you're trying to, correct it.
Right.
So that would have been nice here. I don't think it significantly affects the paper, but I do think it would have been nice to mention. And then for background, they talked to us about sildenafil and how it works. And there's something very interesting in here, so I want to bring it up. Yeah, and that is in the second paragraph here, where they state, the pathophysiology of oligohydramnios is not well understood, but when detected in the absence of rupture of membranes, has been considered to be a sign of chronic suboptimal placental function. Now they have a reference here. Now, one of my things I love to do is go read people's references and see if the reference actually says what they are using it for. And so I did that here. And what they're quoting here is a paper from Sherman et al. In 2005 in the Journal of Perinatology. And while it does, state that fluid levels are a sign of placental perfusion, all of that data comes from sheep. Mm-hmm. So not to say that it's not true, but it was kind of a strongish statement for only data from animals.
I mean, truth be told, a lot of our understanding of placenta in general is extrapolated from sheep data. Only now are they really starting to come up with true human models and better in vitro studies using functional MRIs and newer technology. But a lot of our assumptions and underlying presumption is from sheep data and well antiquated sheep data.
All right, well, there you go. And again, I don't want to make it seem like I'm saying they could have done better here. I mean, sometimes you just have to work with the data that you have available and the references that are there, and it can't be done a different way. But I do like to, know where they're quoting from. And so in the next part here, they tell us about Viagra, which is sildenafil citrate, and the fact that it's a vasodilator, which is presumed to lead to vascular relaxation and increased uterine blood flow. And again, they have a reference here, so of course I went and looked it up. This particular one is an interesting reference. They took myometrial biopsies from women with and without growth restriction affecting the pregnancies, and they incubated those biopsies with Viagra, and they found that the biopsies from the women with the growth restriction dilated and that the other women didn't. And so they're presuming that at least in cases of growth restriction, that Viagra can cause vasodilatation, or dilatation, of the myometrium, and therefore increase blood flow, which is interesting, but I'm not really sure that it allows them to say that Viagra leads to vascular relaxation and increased uterine blood flow.
They make a leap. They definitely do make a leap, and if you read the title of that paper quickly, you may read it as Viagra helps with growth restriction. But you have to look at the next level down where they took a part of the pathophysiology they believe leads to growth restriction and showed some improvement. So one step or one brick in the wall possibly, but again, not a causal relationship just yet.
Yeah, and again, I don't want to say they shouldn't have used that reference, but I think that the line that they wrote and they referenced doesn't really go together, and they could have written that a lot more transparently.
Correct.
And again, I don't know that they're actually wrong. I mean, it makes sense that Viagra would increase blood flow to the uterus because it works on smooth muscle, so that's makes sense. But I don't know that it's as ironclad as they made it seem.
But there is a world of difference between the uterus and the placenta, and that's the part we still don't quite understand.
I think that is a very, very good point. I had not thought about this paper in that light, where we're trying to affect the uterus and therefore affect the placenta.
Right. Just a thought.
Those two things don't necessarily go hand in hand.
Right.
I hadn't thought of that.
What's good for the uterus isn't always good for the placenta, and vice versa.
Okay. So this is why I have smart people like Dr. Ballas on.
And we should also have a disclaimer that we are not sponsored by Viagra nor take any money from them.
That is a good point. We are not sponsored nor take money from anybody.
There you go.
So there's our disclaimer. Now we get into probably the most important sentence in the entire paper, and that is their aim. And they state, and I'll quote it, "The aim of our study was to compare sildenafil hydration therapy with hydration alone in improving the AFI in pregnancies complicated by idiopathic oligohydramnios and to assess pregnancy outcomes of both groups." All right, so let's unpack that a little bit. The aim of our study here, they're saying, was to compare giving Viagra with hydration versus just hydration alone and see does that affect the AFI. Sounds pretty simple. And they also tack on this last thing, which is pregnancy outcomes. Now, one of the things, and Jerry, I know you read a lot too, is you'll see in most papers, they'll tell you what the primary outcome and what the secondary outcome is here.
Correct.
And so I'm going to assume that since they said it first, that comparing, and seeing if the AFI improved is their primary outcome. Would you agree?
Yes.
Okay. And that becomes important when you're reading papers because most of the time, almost I would say maybe 100% of the time, if anything can be said to be 100%, that the study is powered to the primary outcome and nothing else. And so anytime you have a secondary outcome or a subgroup, you really have to consider what their numbers were in those groups to see if really they can even make a statement about it. Whereas their primary outcome hopefully is powered so they can make a real statement about it. And we'll get to it in a second, but in their small study here, I'm surprised they even talk about pregnancy outcomes because it's such a small group.
Right. Well, I mean, in a way, this day and age, you kind of have to. If you're going to submit to an article, because the next question from the reviewers always is going to be, how does this help us? And so, they made the attempt, they took a swing, and, well, lo and behold, as we'll reveal later, there's a couple of significant p-values, but we'll talk more about that in a little bit.
All right, so then I guess we're done with the intro there, and I think, overall, it wasn't a bad intro. I do appreciate brief intros in general. I do feel, I think you agree, that they could have had a little more background in maybe another paragraph to tell us a little bit more about the bad effects of oligohydramnios and what they're trying to prevent. But overall, I think it was a pretty well-structured intro without too much fat.
Agreed. Okay.
So let's move on to the methods then. So this was a open-label randomized control trial. The reason it is that way is because they gave some of the women a pill and some women not a pill. So they did not do a placebo here. They just either gave them, so the women know they were getting a pill or weren't getting a pill. I'm not really sure why they decided not to do a placebo.
That's actually high on my mind. I was going to bring it up a little later, but we'll circle back to that.
Okay, we'll put a pin in that for later. It's really not that much harder to do a placebo, so it's a little interesting choice. Any case, then they mentioned that it was IRB approved, which is kind of standard these days anywhere in the world for doing, especially a trial like this where you're giving an intervention. And then that they registered it with clinicaltrials.gov, which is for those of you international who don't know, that is a U.S. registry of clinical trials. And pretty much these days, if you're doing any kind of interventional trial and you are not registered with clinicaltrials.gov before you start the study, you will not be published. Jerry, you
agree?
I mean, that seems to be the impression I get.
Oh, okay. Absolutely. And your, your individual local institution could come down on you pretty hard.
Yeah, and it's interesting. I guess for people who do tons of research, they know about this. I do a little bit of research, which you guys have heard me talk about a little bit on the show before. And so the first time I did a real study kind of like this, I just kind of came across the fact that it really needed to be registered with clinicaltrials.gov, and I knew nothing about it. So anyway, public service for anyone out there who's going to be doing clinical research. All right, so then we get into their inclusion criteria. And again, so this is, I said the aim was the most important part of the paper. Well, this is going to be our second most important part is our inclusion and exclusion. So they decided to include singleton pregnancies at over 30 weeks with an amniotic fluid index of less than 5. And that sounds appropriate for what they're looking at, right?
Mm-hmm.
And then this is interesting to me. So they say that all these women were discovered after having a routine ultrasound. Now, obviously, Jerry,
Mm-hmm.
you're an MFM, and so your practice is different than mine. But we don't routinely do ultrasounds at 30 weeks.
Right. Well, you'd be surprised, and I'm learning this more and more. In Europe and a lot of parts of the world, they are starting to add the third trimester growth scan as part of a routine evaluation. So I actually have a lot of patients that come in from overseas, and we're talking everywhere from Europe to Middle East to Africa, whose practitioners, would scan them every 6 weeks if they wanted. So there's a lot more ultrasound going on. You'd be surprised in other parts of the world than there are here. So between 20 and 32 weeks, there's a lot of women getting routine scans overseas.
All right, well, there you go then. And, for our listeners out there, and those of you who have joined the Slack, if you are, working someplace outside of the States or even someplace in the States where, the routine is for you to do those ultrasounds at, say, 28 or 30 weeks, then please, write in and let us know. Love to hear from you. In any case, so moving on to the exclusion criteria, they excluded the following women. Any women with fetal anomalies, abnormal Dopplers, which also goes along with IUGR, which they also excluded, which we'll talk about in a second. Women in labor with rupture of membranes, which is kind of obvious, and then other chronic maternal medical conditions such as kidney, lung, or heart disease. Now, Jerry, I'm sure you're going to agree with me here. For a study that's looking at placental perfusion, interestingly, that they excluded the women with IUGR.
Mm-hmm. Well,
I think.
Oh, go ahead.
Go ahead. No, go.
Well, I was going to say, I think because other trials have not shown an effect on that large outcome of IUGR, I think they wanted to avoid that population because I think we're learning more and more that there's just another level of complication that isn't going to be addressed by a simple vasodilation. And so typically the IUGR kid will come with a comorbidity of some sort that then you start having to control for. So they really, I think, were trying to parcel down to the idiopathic oligohydramnios just for clarity of outcome and to avoid having to either over control for factors or have to explain too many confounding issues.
Yeah, I think that actually raises an important point when you are arranging your own study, is that you want to make the inclusion and exclusion criteria narrow enough that you can say something about what your intervention is,
right,
without, like you said, too many confounders. And at the same time, you want to make it inclusive enough that you can apply it to a large group of people.
Right. And that you can find people.
Right, and then you can find people, exactly. All right, so if you say that, yes, for women who are missing a toe on their left foot, we can give them this medication and their babies will be better, well, that's nice, right, and I'm glad that we proved that, but it doesn't really help me in my usual, daily clinical practice.
Correct. One little caveat I would have liked to have seen also with, AFI versus the deepest vertical pocket is a long time debate going on in the MFM world. And for those of you listening, deepest vertical pocket being greater than 2 centimeters versus AFI of 5. So there are some camps in the MFM world that debate which one is a better assessment of fetal well-being. Some feel that the AFI is a little more of a confounded measurement since it's subjective 4 times over. So I would have liked to have seen perhaps a little more delineation as to whether they included women who didn't even have a deepest vertical pocket of 2. So not just saying AFI less than 5, but what did they do with women who had a deepest vertical pocket less than 2? Because there is some thought that that's a different breed altogether in terms of oligo. But just a little caveat in terms of inclusion, exclusion.
Yeah, I mean, again, I'd have to agree with that. We look at IUGR, the definition most commonly used is less than 10%, but we all know that by definition, less than 10% of babies will be less than 10% because that's how we had the definition, right?
Correct.
And I think we found in the last 10 years or so that it's really like the less than 5% or even sometimes the less than 2 or 3% that are the real, pathologic pregnancies.
Right.
And I think that's what you're getting at here is that an AFI of 5, although it's quote-unquote low, may actually not be that pathologic.
Correct.
Okay. And so even despite their best efforts here with their inclusion and exclusion criteria, they still may be lumping together some women with different etiologies for oligohydramnios.
Correct.
Okay. All right. So then going on to their protocol, they had one ultrasonographer, which was nice. So that gets rid of at least some of the variation. Although, as you just said, ultrasound in general is relatively subjective.
Correct.
And even the same person doing the same ultrasound a few hours apart might get a different number.
Correct.
Okay, so there is that, even though they did use one person, which is nice. They measured the AFI twice on each occasion, and the mean AFI was obtained by averaging the two, so that was their attempt to get rid of some of that variability. So I applaud them for that. Then they took all women, and they admitted them to the hospital. They gave them all 2 liters of IV fluids over 4 hours. Then the women in the experimental group, they gave them the Viagra, 25 milligrams every 8 hours. Now, just as a aside here about that 25 milligrams, because I kind of wonder where they got that from, right? I mean, in some sense, they're doing a new trial here, so they're kind of making it up, but I still wanted to know where they got it from. And it looks like this is the same dose that is given to adults with pulmonary hypertension. And so I think maybe that's why they chose it. Because they at least knew it was safe.
And it's been used in pregnant women with pulmonary hypertension, so they probably have some pregnancy-related exposure studies that make them a little more comfortable using it.
Okay, well, there you go. I didn't know that. That's good. Anyway, it seems like a fine dose. I'm always curious, how they choose these things.
It's not the male dose, because that would be interesting.
Do you know what the male dose
not
is
at all.
Off the top of your head?
Moving on.
Yeah, me either. Okay. All right, that got awkward quick. Okay. So then they found that women over who had a 20% or higher increase in their AFI in 24 hours were sent home either to continue hydrating, and they recommended 2 liters a day, or to go home and do the 2 liters a day plus take their Viagra. Now, one thing I should mention here, and they mentioned it later, is that they didn't actually check to see if the patients were either taking the Viagra or drinking what they're supposed to be drinking. Right. And again, I don't know how you would actually do that. So I'm not saying that it's a fault of theirs, but it's something to keep in mind.
And this is actually where I kind of mentioned the use of the placebo would have been ideal. So here's where a huge bias can be introduced to your study when you do not make your groups as equal as possible in the intervention. So now you have a group of women who are taking a pill. They are prompted to intervene with the pathology you told them they had. So not only are they taking the pill, but you've also told them to drink 2 liters of water. Meanwhile, you have another set of women who you just told to drink at least 2 liters of water a day. So without a prompt, that pill, that magical pill that many patients look for, is there as strong of a prompt to drink the liquid as well? So this is where I think a standardized placebo pill could have taken at least a little of that question out of the mind, because it's a strong, desire to correct what you told was wrong in a pregnancy. A woman is going to use every means necessary, and if you give them a pill as a prompt, they're going to drink that water as well. So that's one question I had about not using a placebo pill.
I couldn't agree with that more, and stress the importance of why most of these kinds of studies are done as a double-blind study where neither the doctor nor the patient knows if they're getting the medication or not.
Correct.
And especially, I agree with you. It could be either way, but probably women who are taking the pill were more likely to drink because they're being reminded every 8 hours to drink more. But you could also, envision a situation where women are saying, well, I'm taking the pill, so I don't have to drink that much.
Another way to
So
look
you can
at
see
it.
both ways.
Yeah.
I think yours is probably more correct because every pregnant woman I know, who is in a situation like this is probably drinking 4 liters a day instead of 2 liters a day.
With each pill.
With each pill. Exactly. So, but there's still bias in there from the patient side. Then they go on to say that women were monitored twice a week with non-stress tests and then once a week with an AFI and biophysical profile. Then women were readmitted if they had persistent decreased fetal movement or if they had abnormal testing, which makes sense. And they recommended bed rest and daily kick counts for all the women. Again, they don't know how many women actually did that, if they actually rested or not, but they did recommend it. Then we get to a primary outcome. Yes. All right. So they tell us the primary study outcome was the amniotic fluid volume at 6 weeks of follow-up or the final volume before delivery, whichever occurred first. Now, I'm going to state that again because it's very important to the results. So the primary study outcome was the amniotic fluid volume at 6 weeks or the final volume before delivery. Right, whichever occurred first. So we're going to come back to that. So stick a mental pin in that as well. We'll get back to it. The secondary outcome measures were randomization to delivery. So basically from the start of the study, how long till they were delivered. The mode of delivery, gestational age at birth, and neonatal outcomes including neonatal weight, APGARs, pH, and admission to the NICU. Then they tell us their power calculation. Which is actually based on a decent study using just maternal hydration therapy alone. So they assumed that Viagra, when combined with hydration, would increase the fluid levels from a 30% increase in this trial they quoted to 45%. So they're saying an increase of 15% difference in AFI by adding the Viagra, which, it's made up, but it sounds like a reasonable made up. So doing that calculation out, they got a sample size of 167 women, and then they included an extra 10% for losing women due to dropout for whatever reason. All of that is a very smart way of going about designing their study.
Yeah, no, I think the authors did a very good job of, at this point, very clean, straightforward explanation of their statistical outlook and what they were planning on doing. Pretty standard fare. The data that they were collecting, the categorical and continuous variables, they have pretty well covered with what they were planning on doing. So, they're on the ball with the statistical analysis and planned analysis for the group that they have.
Yeah, and then looking next at their stats, I'm not going to go through all their stats. Neither Jerry or I are statisticians, but we know enough about stats to look at this and say that it seems like they used the appropriate stats, or at least they know which stats to write down that they used. This is one area of scientific research, and I don't think you're going to get any arguments from anyone else when I say this, that is really probably the weakest part of literature. Because there are many ways to examine data. You need to make sure that the data is normalized if you use certain tests, or if it's not normal, use other tests, so on and so forth. And we have no way of knowing if these authors did that. Now, I'm not saying this against them. I'm saying in general, in scientific literature, we don't know how the data was analyzed and whether it was analyzed correctly. And that is one of the black boxes of scientific literature, which I don't really know how to get around, but it is concerning.
Well, I mean, I could tell you from experience, my background is years and years ago in epi and biostats. And I could tell you a strong research institution, or at least a smart researching team, will get a solid statistician to look at their data and make sure, because you'd be surprised if you tried to sneak something through, either at the poster presentation or to a letter to the editor when your paper gets published, that somebody will look at this and say, your data is not normally distributed. How did you use that statistical analysis for that? So I do agree. There is a lot of black box component to this, but man, you'd be surprised people waiting to kind of catch you on stuff.
Well, fair enough. There you go for a crowdsourced stats. There you go.
Exactly.
All right, so I think that we're at a pretty good point here to move on to the results. I'll agree with your little mini conclusion there on the methods. I thought it was well written. It was straightforward. You can disagree or agree with some of the choices they made, but they stated their choices clearly. All right, so let's move on to the results. So they took... They screened 184 women who randomized, and they ended up with 166, which was exactly 10% dropout rate, which is what they had figured. They had 82 in their Viagra group and 84 in the hydration group. And then they tell us about their demographics, which were relatively the same.
One quick thing I'd like to take back, and I realized I wrote the word N, and I circled it next to this, N with a question mark. I'd like to know what their total volume of patients were it took to find these cases. That would be my one curiosity. Idiopathic oligohydramnios, overall, I gotta say, is fairly rare. It's not uncommon, but I'd be curious to see what their overall volume was, or delivery volume, or how many women on average they see to get a number of 196. It kind of gives you an idea of the scope of the problem that they're looking at.
I think what you're getting at there is interesting. It's about looking at the population that they're dealing with. If, say, in our population of women, the incidence of idiopathic oligohydramnios at 30 weeks is, say, 2%, and theirs is 10%.
Right.
We have to ask ourselves, is there something else going on in that population?
Correct.
And I think that's an interesting point.
Right. And then I'd also say, bless them that their average BMI is 24.9. Jeez. They obviously do not practice in Texas.
Well, I can say in most places they don't practice then in the U.S. because you are not alone in having a high average BMI, although definitely the South has been known to be slightly higher. But yeah, I mean, otherwise their demographics are relatively similar. I will note the large range in a lot of the values there. So even maternal age 20 to 46.
Yep.
And I'm surprised they found enough 46-year-olds or some 46-year-olds with no chronic medical issues who were pregnant, but God bless them.
I almost consider over 40 a chronic issue of its own, because we do, monitor over 40 differently towards the end of pregnancy, and in our institution at least advise delivery between 39 and 40 weeks. And so that does bring up an interesting point. I didn't see anywhere, I know they gave us the average and the mean, but I wonder how many of those patients were over 40. Question for another day.
Yeah, agreed. And then the only other thing I want to bring out here is the mode of conception. There were, I don't want to use the word significant, but there were definitely a few more of the reproductive help women in the hydration group only than in the Viagra and hydration. Now, again, they don't give us p-values here. I'm assuming if it was significant, they would have told us that. Right. But there certainly are a few more there, so it's interesting. And the last thing there is the gestational age at randomization, which is identical actually in both, and even the ranges are pretty identical. Although I will mention that the top 35.3 and 35.9, it's interesting to include a woman like this at 36 weeks with oligohydramnios, because I'll tell you at my hospital, if she was 36 weeks with oligo, she probably wouldn't be pregnant too long. Well,
this also brings into the deepest vertical pocket, because we will start at that point even dividing it out even more. If I can get a 2x2 pocket at 36 weeks, I'm comfortable forging ahead. Not much longer, but at least can get her into the early term category. So that's why I would have loved to have seen that little breakdown as well.
Agreed. And actually that brings up something that I didn't mention in the methods, because they don't really mention it. They do mention it somewhere in the paper though, is about why these women were delivered. Mm-hmm. Right? There is no criteria for delivery. So what I'm guessing happened here, because again, they don't really tell us, is that these women weren't necessarily under their care, that they had a primary obstetrician who was responsible for delivery timing and delivery decisions, and that they weren't involved in that decision making.
That would have to be my assumption.
Okay. And so that definitely, when we get into their primary outcome, which we'll talk about in a minute, that definitely confuses things because we don't know were they delivered because their fluid went down further, were they delivered for non-reassuring tracing, were they delivered because, I don't know, they were 36 weeks and their doctor said, I'm tired of dealing with this, let's deliver them? Well, we don't know. Mm-hmm. And it makes it difficult to interpret their outcome because their outcome was either delivery or at 6 weeks, especially when we talk about some of their secondary outcomes. All right, so moving on to the next table, which is Table 3, where they tell us the AFI for both groups, and they break it down by each week. And they also tell us the number of readmissions and how long they were admitted. Do you have any initial thoughts on this table?
Well, right off the bat, they really are impressing with showing their significant p-values, which every researcher wants to put on their first, big table. And so right off the bat, you're looking at this and you're saying, obviously, sildenafil helps. That's your initial reaction here.
Right, so they're looking at number of readmissions. Almost none of the patients in the Viagra group were readmitted. Mm-hmm. So that when we're assuming that their NSTs were normal and their IFI was normal, whereas I'm trying to look at it now, 43 so half the women were readmitted once or twice in the hydration alone. So there's something there. The AFI after the first treatment, so I guess that's the admission, was similar between the two groups. And remember that their average AFI at admission was 3.4, and they showed basically a doubling of the AFI in both groups. So interestingly, the Viagra didn't really seem to make a difference, at least in the initial treatment. Mm-hmm. Right. It was 2.8 and 2.9. So it was pretty much the same. And then they go in by week. Now, one of the things to look at this, looking at this table, is how many women are still pregnant mm-hmm. at each one. So in the Viagra group, up to week 3, pretty much all the women are still pregnant. And then you start seeing a fall off. So it goes from 82, 82, 82, 76, 65, 33. And then in the hydration alone group, there's a pretty steep fall off over the week. So it's 84, 83, 67, 28, 6, and then 2. Mm-hmm. And so this is going to become important when you look at their primary outcome because, again, that was either at 6 weeks or at delivery. So there's a big difference in the number of women that were delivered there. All right, so then so that's their primary outcome data there, and I'm going to ask that we delay talking about the result for primary outcome for a minute, and I want to move on and talk about their secondary outcomes first, which I know sounds a little backwards, but bear with me. So for Table 3, which is their secondary outcome, again, as Dr. Ballas says, they really like their p-values here, and they have a lot of significant p-values. Now, of course, one of the things I always teach my residents when we look at papers, you have to remember that there's a difference between statistical significance and clinical significance. Right, so you can have a statistically significant difference of a few points, but clinically that's irrelevant. And we get into some of that here. But some interesting things that they found, or I thought were interesting anyway, and Dr. Ballas, you can chime in, mm-hmm. is one is, not surprisingly from the last data, the gestational age at delivery was much higher in the Viagra group, which we could have guessed based on how many, what weeks
right.
they were delivered. Yep. And again, going with that, the pregnancies were prolonged much further in the Viagra group. So, but here's where it gets interesting to me, and the first one is the meconium staining, so much higher in the hydration-only group. What do you make of that?
I mean, if you look, kind of look at this all as a group, the meconium staining, the abnormal tracing, and the, let's see, C-section being 4 abnormal. I mean, all of this in one way does look like the classic sequelae from a fetus without a lot of fluid around, maybe having a lot of variables, going through fetal distress, causing meconium staining. I mean, that's kind of the classically taught, triad of fetal distress, which is low fluid, cord compression, repetitively meconium staining.
I agree. And, two things come to mind when I'm looking at this data. One is, either the populations are actually much more different between the two groups than we think for some reason, which I find unlikely, because I actually think they did a pretty good job randomizing.
Right.
Or maybe the Viagra, because I guess let me go back and say this again. With increased fluid like you're talking about, it seems to me that fetal distress and all that kind of stuff, obviously that usually goes with poor perfusion to the fetus, right? And you can see that in the abnormal tracing and the abnormal Dopplers.
Right.
So is the Viagra, I mean, we're using fluid as a proxy here, but maybe their statement in the beginning of the introduction really is true, and that Viagra really does increase blood flow to the fetus.
So you're thinking it's more of a placental effect than a uterine effect.
Right.
Interesting theory.
Well, I mean, these outcomes here, these are the things we see in women, babies with IUGR and things like that, as opposed to, kind of your run-of-the-mill oligo. I don't know. It was interesting to me. We have no way of proving that. They have no way of proving that. But food for thought. Moving on to the neonatal outcomes, and I will tell you that in general, I'm going to use the word detest, and that may be too strong a word or not strong enough a word. But I usually detest neonatal outcomes because in order to find significance in neonatal outcomes, generally they end up pooling them and making a neonatal composite score or something like that. They didn't do that here, thankfully. But the thing they also didn't do was control for gestational age. And I'm going to imagine that a lot of these differences here are due to the fact that they were much more premature in the hydration-only group.
Yeah, no, I could definitely see a 3-week difference in your average gestational age. Obviously, the neonatal weight, you're always going to get a great p-value out of that if you have a group that delivers 3 weeks earlier. Admissions to NICU. Yeah, so this is all, I agree, related to gestational age.
Right, which isn't obviously to say that obviously the experimental group here got a benefit from the medication because their pregnancies lasted longer.
Correct. And
that all goes with neonatal outcomes, so I'm okay with that. And I can't actually remember, we'll get to the discussion in a little bit, whether they make a statement about the Viagra for neonatal outcomes, but I could see someone saying, oh, look, well, Viagra improves neonatal outcomes, based on this data. And that's not necessarily true.
Go back to an interesting point you made. You got my brain going here. When you were talking about could the Viagra be having its primary effect on the fetus, the cord, maybe the placenta itself. Another group that's notoriously known to have a high rate of meconium staining are our cholestasis kids. Right? So our cholestasis pregnancies, which we still don't know what the exact pathophysiology behind demises or abnormal tracings in labor or the abnormally high meconium staining that comes along with it, but it's always been proposed that there is a vasoconstrictive effect of these bile acids on both placental and umbilical cord circulation. So could the Viagra effect actually be an effect on placental and cord vasodilation that's protective to the fetus in labor? Fascinating. Just a thought
Absolutely.
Off the top of my head.
The further we get into that sort of stuff, in many ways, the baby and the placenta are still a black box to us. Like, we don't really understand how that all works, right?
Correct.
And I think this paper actually it hinted at a lot of things that were much more interesting to me than just fixing the AFI.
I would have loved if they had gotten cord blood samples and measured the level of Viagra in the cord blood. That would have been
Absolutely.
a nice caveat to this study.
Yeah, agreed. All right, so now let's circle back to their primary outcome. I do want to mention, by the way, that their entire results section is only 3 paragraphs long, and they are three very short paragraphs. And again, like I said in the introduction, I'm all for brevity, but this is a paper that probably could have benefited from maybe a couple more paragraphs in the results.
They just, I'm telling you, it's a p-value showcase, and so they really just direct you to the tables. I think that was their aim.
Yeah, I mean, and there is 2 schools of thought when it comes to writing, and I shouldn't actually say 2 schools of thought, because the one school of thought that is the right one is that you should be able to read the paper without tables and understand it, right? However, that runs up against publishing realities of how many pages that they want to publish, because each page in a journal costs money, and a lot of money. Especially in a very large journal like the Green Journal, which is distributing, I don't know how many thousands of copies every month. And so they try to keep the papers as short as possible. And places like New England Journal of Medicine now are publishing a lot of supplemental stuff online with the full methods and things like that. But in any case, it's still kind of a short results section. But let's go back to their primary outcome. So you will mention, because I said it twice, you'll remember, because I said it twice, that their primary outcome was either the AFI at delivery or at 6 weeks, whatever happened first. So let's read I'm going to read the paragraph where they discussed that primary outcome in the results section. All right, so they state the amniotic fluid volume was higher in the Viagra group at the final assessment, 11.5 versus 5.4 with a p-value of 0.02. Now, that is not the same thing as their primary outcome. They're just telling you that's 6 weeks. But of course, if you go back to that table with the weeks in it and who was still delivered, there were only 2 patients left in the control group. And so that's why they had their primary outcome to begin with, was we want to know at delivery or at 6 weeks, but they only reported at 6 weeks.
So you'd like to see kind of matched by match weeks of delivery with AFI at that time?
Well, I mean, first I'd like them to just answer their primary outcome. Mm-hmm. I mean, they're the ones who made it up. I didn't make it up for them. So I think they should have given us results based on that. And you can't even really figure it out. I guess you could figure it out from the table. They do give you the AFI and the number remaining. So, I mean, you can come up with an estimation, I suppose. Mm-hmm. But, you know, that was their primary outcome. And I think correctly that was their primary outcome because, I don't know, actually. I'm a little confused. So, even we're going to assume that most of these women were delivered for either non-reassuring antenatal testing or because they were persistently oligo.
Well, that would have been a nice secondary table to put in here. Indication for delivery.
Right, and again, I think because they didn't control the delivery, they maybe didn't have access to that information. I'm not really sure, but it makes it hard for me to interpret that primary outcome when I don't have the information. They don't give us the information. Mm-hmm. I actually, amazingly to myself, don't actually think it takes away that much from the paper. Although I think it may change the way they conclude in their discussion. But I did find it odd that they chose a primary outcome like they did and then didn't give us the data to tell us what the answer was.
Well, to tell you the truth, I think when they were formulating the study, and again, I'm trying to, at this point, the defense attorney would object and say I'm trying to figure it out. But it sounds like a great outcome if you think about it. But then reality hit that not every woman's going to be still pregnant after 6 weeks. And I think they realized it's a whole lot more work, which I think would have enriched the paper and the understanding of this population more if for every individual woman they had recorded the indication for delivery, what the AFI was at the time of delivery, and analyzed it in that regard. I would have loved to have seen AFIs at time of delivery. And maybe even create an index of some sort of, AFI, at such and such week and standardize all the women. So all the women that delivered at 36 weeks, what were their AFIs? 35 weeks, 34 weeks, 33 weeks. So I think that would have been another way to look at it. And I think it would have been a little more clinically logical way. I would want to know that, okay, I give a woman I start Viagra at 30 weeks with hydration, how far can I realistically expect her to deliver, and how good how good of the fluid is going to be, and how good of an outcome am I looking to affect with this intervention?
Yeah, I mean, one of the things I took away from this is I actually compared this to amniotic fluid infusion during labor for women who have variables, not amniotic fluid, you know what I mean, and which we know doesn't actually affect the baby, but it allows us to allow them to labor, and so we get more vaginal deliveries.
Correct.
Right. The only thing is treating is the provider.
Right.
And I almost feel like we're in a similar situation here, where we are allowing the pregnancies to go on more,
right?
Because the fluids are higher. Now, one caveat to that is that we did see in the hydration-only group that there was a higher rate of meconium staining and all that stuff. So maybe there is some fetal effect that we just didn't answer in this study because it wasn't designed that way. But I really, at least in some way, really feel that we're treating ourselves here.
Absolutely. No, I can see a definite component of reassuring physicians to continue on with a improved AFI.
All right, so I think we've beaten the results section to death, and we can move on to the discussion. And this is where this, as far as scientific literature, this is where this paper starts to fall apart for me. Up till here, with it, like I said, I have some quibbles. Maybe I would have done something differently. Maybe I would have chosen a different primary outcome or secondary outcomes. But the way they've presented it so far, I think, has been pretty clear. And my biggest problem with the discussion is when they get into their strengths and weaknesses, because they're interesting, to say the least. But before I get there, I want to talk about, again, speaking about literature, is the first couple of paragraphs in the discussion are essentially, in my mind, introduction. Because here they start telling us about the Viagra and how it may work, and they tell us finally about why AFI may be a bad thing, right? But that's all. That should have all been in the introduction.
Correct.
Right? You should, as a general rule, never introduce new information in the discussion.
Right. I mean, I could definitely see starting with considering the enigma as the opening line of your discussion. That seems much more natural.
Exactly right. So, in any case, again, that is that's about writing and literature. It's not necessarily about the research, but we're here to examine it all today. So, then after we now have moved their 2 paragraphs to the introduction, we can get into the rest. So let's talk about those strengths and weaknesses for a second here. I want to go one by one because I find them, they're fascinating to me. I spent a long time thinking about them. So their first strength, they tell us, is that it was randomized with adequate randomization method. Now, I don't disagree with you, but I don't know that it needs to be listed as a strength of the paper because it's obvious. Right? If you didn't do an adequate randomization, and you don't have to tell us it's computer-based.
I think they could have easily just said randomized in order to reduce variation between, or in order to reduce potential biases between groups. I mean, that's what randomization is, the definition of randomization for research purposes. So they could have simply said this was a randomized trial. That's a strength.
Exactly.
Most places, it's hard to get a randomized trial up and running that gets published.
I've now tried to do a couple randomized trials, and I have published neither of them, so I can attest to that personally. The second one, this one just blows me away. A power calculation was performed.
Well, what they're getting at, I think it's actually a bit of a dig at the studies that they referenced earlier on. They kind of made them sound almost like case series in a way, like descriptive studies. And so what separates a descriptive study or an observational study from an actual intervention study is a power calculation. They put themselves out there and said, we're looking for this difference, and we're going to go at it, rather than somebody just collecting a lot of data and saying, here is the differences we saw.
All right. I mean, I see that. I also wouldn't have written that in the paper.
Yeah, that's an interesting one.
Yeah. But I do agree with you. They're trying. I think now that you said that, I see they're trying to contrast themselves against the other studies that have come before. And I get it. And they really could have just said a randomized, randomized study that was adequately powered, and I would have said okay if they phased it that way.
Adequately powered with a stated primary outcome.
Yeah. I'm going to take a step back for a second. So as I've told all your listeners before, I'm the associate editor on a couple of journals, and it's a international journal. It's based out of Germany. There are lots of people who submit who English is not a primary language for them, and there is a lot that gets lost in translation. And so sometimes it's just a matter of English not being their primary language. And so I always try to keep that in mind, especially when dealing with a paper that is not from a primarily English-speaking place. So I will give them a little latitude in there that maybe it's just an English thing, but still interesting. You think that the reviewers might have said something here, but maybe not.
And I've reviewed. I'm a reviewer for a couple of journals, and I will return with a specific consider. Running this through a English-speaking colleague or a service. A lot of places will offer services now. And actually, I think, if I remember correctly, the Green Journal, if you read their submission guidelines, it's kind of a novel. But it will actually, I think, give a resource or tell you explicitly consider an English resource to vet your paper before submitting.
Yeah. I mean, it definitely, especially in some places like the Green Journal, where they get so many submissions that if yours is not that readable, they will just kick it out right away. Yeah. All right, so let's move on to their third determination of either persistently or just temporarily increased AFI by continually following patients until delivery. Again, now that you've phrased it and they're trying to contrast themselves against other papers, that makes a little more sense to me. To me, it just sounds like good study design. But. Right.
Well, I think they're, again, contrasting that this wasn't retrospective, that they put in the legwork to follow them prospectively, which gives your paper a little more credibility, prospective.
Yeah. And then the last two are interesting to me. One is number 4 is a wide range of gestational ages were included, and I actually don't know that was a strength because it really depends on what they were trying to show. Right, so that one's a little weird to me. And if you're going to put that, then I think they need to justify it. And then the clinical importance of improving AFI was assessed. And I don't really know what that means.
Yeah, no. Yeah, that's a kind of a throw-out sentence there.
Right, and B, I'm not really sure, because remember, folks, that this study was not powered for outcomes. It was only powered for the difference in AFI. That was it.
Right.
And so even though they showed all those p-values there, you have to keep that in mind. All right, so moving on to the negative aspects. So these are the limitations. Again, I would probably not write negative aspects. I would probably write limitations, but that's a matter of choice, I suppose. One is AFI measurement is subjective and difficult as a result. It's basically subjective, which I think we all agree is a limitation. That 2 normal pregnancies before 30 weeks of gestation and pregnancies with maternal or fetal complications were excluded. Again, I'm not sure what they're trying to get at there. I don't really know how that's a limitation. I mean, it is in some ways in that it limits how you can apply this information to your own patients, but it doesn't really limit the study.
Right.
Yeah. 3, maternal position was not standardized during therapy. Again, they showed us no data that maternal position should matter.
Right.
And so it's odd that they put this in there as a limitation. And the only thing I can think of is maybe one of the reviewers made a comment about this.
I was about to say that I'm sure they got a reviewer that's a stickler for AFI or wrote a seminal paper in amniotic fluid and put that in there saying you have to tell us the position. Are they left lateral? Are they supine, etc.? So that sounds like a reviewer added weakness.
Okay, I agreed. Compliance with treatment was not assessed. That's something we talked about already, and they acknowledge it. The characteristic of amniotic fluid, such as solute contents after treatment, were not studied. Now, do you know anything about this?
No, I mean, this maybe gets to there's some papers out there that talk about sludge, that talk about echogenicity of amniotic fluid. Some papers have shown worse outcomes or earlier deliveries in pregnancies with notably echogenic amniotic fluid. We don't know what the etiology is, whether it's meconium and there's something vasoactive going on, or it's just some of these studies are retrospective, and again, you got that retrospective bias creeping in some of these studies. So that would be my guess, is what they were including is perhaps there was something else going on that they didn't assess because they didn't comment on the appearance of the amniotic fluid.
Okay. Yeah, that's interesting. Then number 6, only AFI indices and not the actual amniotic fluid volume were used to reflect improvement after therapy. Now, if someone could teach me how to measure the actual amniotic fluid volume, I'd be very happy. So I thought that was a little weird. And again, maybe that's from a reviewer, because it's kind of out of place and it's not mentioned anywhere before. Yeah,
again, I think it's you'll sometimes get some sticklers kind of correct. You'll hear them correct the resident. They'll correct their fellows about amniotic fluid index not being the actual amniotic fluid volume. And the only way you can do that is either through actual volumetric imaging or through actual volumetric subtraction by submerging women. And so they'll go through a whole academic discussion about the difference of AFI versus AFV.
Okay. So maybe they should have done MRIs on all these women.
That would have been fascinating, expensive, and really probably would have gotten yelled at by the IRB.
And then the last one, this is probably the largest, the biggest limitation, which we already mentioned, is no placebo was given to the hydration group.
Correct. And that's a mystery to me. Like I said, producing a sugar pill that looks like your medication is a fairly common, easy thing to do these days.
Yep. And so, I mean, really, I would only say out of all these limitations, there's probably only a couple that I would actually consider are limitations. Mm-hmm. But that's okay. Before I get to their conclusion, which is, again, nice and brief, is there anything else you want to talk about and what they... I mean, I didn't go through their whole discussion about what they say about the results, because I think we covered it in other ways, but is there anything else you want to say about it?
No, I was hoping to get to that concluding sentence as well, and we're probably going to have similar takes on what they probably should have kind of framed it and said, rather than the way they stated it, but I will let you proceed, because we've been pretty much... eye to eye so far. I'm curious to see what your take is.
So they wrote, in conclusion, our findings suggest that Viagra may offer a new opportunity to improve pregnancy outcomes for women with oligohydramnios. That's a bold statement.
Yes, it is.
Yeah. So I think that if Dr. Ballas and I haven't done a good enough job at breaking down their that statement already, then we haven't done a good job talking about this. I mean, nothing they put here really supports that statement.
No, I think they could have been much more. And I'm surprised the reviewers, because I can tell you I've been rejected many a times, and a lot of the rejection comes with language and stating your conclusions, overstating the importance of your data. And this is a sentence that simply could have said, our study suggests that sildenafil with hydration may improve fluid status of a pregnancy in the 3rd trimester.
Yep.
If you wanted to be bold, you could add a sentence that says, such improvement may aid in guiding physicians later in the pregnancy in terms of delivery and perhaps improving outcomes. Something a little more, open-ended. Some mays, some considers. Correct.
Things like that. Because, again, remember their primary outcome and what it was powered for was to just see if the AFI increased. And I quibble with their primary outcome because they didn't actually address it. But they definitely showed that they increased the fluid volume and kept it higher in the women with the Viagra group as opposed to the just hydration. So they definitely showed that, and I'm not going to argue with that. And even though we don't know why the women were delivered, if we assume that they were delivered for non-reassuring antenatal testing and for persistent oligohydramnios, you can just see in the fact that so many more of them were still pregnant at the end of the study that it had some effect on the fluid, right?
Or the physicians.
Or the physicians, or both. And so there is something here. There's something to sink your teeth into here, and I really like this study. I would never have thought in a million years of giving Viagra to a pregnant woman for oligohydramnios. Now, obviously, other people have, and that's why they're here. But I thought it's a little outside the box for most, practicing, providers. And so I was really taken by this, the idea of it. And their execution and their study was decent. Like we said, the limitations were already. But I really liked it, and I really wanted to like this paper. And then the discussion ruined it for me.
Yeah, no, I could see where you're coming from, and I know, being an MFM, I've seen Viagra, sildenafil kind of being applied for maternal reasons, like we talked about pulmonary hypertension. We're seeing more and more of it being used. The hope that in terms of fetal growth restriction, women with that we know have poor vascular disease could improve outcomes. That's still in the works. So for me, seeing it applied to oligohydramnios as a way of framing placental insufficiency, I actually thought it was a great next step to take. And I agree their discussion goes off the rails a little bit, and then, kind of just gets into this haphazard strength and weaknesses argument that they probably could have cleaned up a little bit more. But I think overall, great discussion generator, great idea, hypothesis. Just sitting here, I've thought of a couple of things in terms of, cholestasis pregnancies. I'd love to do a study where I actually measure the cord blood amount of Viagra to see if there's a possible fetal effect. Could they have done things like ductus venosus studies and Doppler studies within the fetus, MCA Dopplers? That would have been interesting to see in order to measure fetal effects and placental effects, and even doing placental biopsies. I would have loved to have seen placental biopsies between these two groups and see if we can correlate with reference number 3 about dilated vessels in groups treated with Viagra or not. So this study can go in many different directions. I think it's a great hypothesis driver. I don't necessarily think I'll be inviting the Viagra rep over to my practice anytime soon, but definitely some conversation starters at work.
All right, so that leads us to 2 more things, and then I promise everyone we're almost done here. We're wrapping up. One is this applicable to our patient population? And I think we both agreed that we have women like this in our population.
Yep.
You probably have more than I do, given how you practice. So it is applicable to our patients, but I think we can probably both agree that we're not going to apply it to our patients yet.
Yeah, no, I think I'll have a little more of a wait and see approach. I will discuss it with patients. I do believe in kind of picking the right patients, telling them about research, getting their consent, explaining the limitations just like we did tonight, and letting them make their own decisions. I would be interested to see who would go along with this or not. My own head, actually.
So you would actually offer this to women?
I would talk about it. And explain how it's not a regimen that's currently proposed by our governing bodies, but there are studies out there to show possible improvement. So.
Okay. Well, there, folks, is a difference between a general OBGYN and an MFM.
I'd ask you to refer your patient to me. No.
There you go. Exactly right. And so the last thing I want to finish up here is I want to talk about their abstract. Now, the abstract is usually the last thing that gets written because you are abstracting the paper, so that makes sense. But it's also the first and usually only thing that people read. Mm-hmm. And so I always like to look and see, does the abstract adequately reflect the paper? So I'll open it up to you first.
Yeah, no, I think overall, I think it does a pretty good job. I think it actually seems longer in the methods than I would have thought, having read the whole paper, the results section actually seems longer too, but I think they did a decent job highlighting what they wanted to show you. But definitely reading the paper and analyzing like we have was a must, because if all you did was, sit on the toilet, read the abstract, you're done, and then go on, you may have a skewed concept that Viagra will cure oligohydramnios.
Right. And actually, I will say that their conclusion in the abstract is better than their conclusion in the paper.
Correct.
So the conclusion for the abstract is that Viagra increases amniotic fluid volume in pregnancies complicated by oligohydramnios. And I say, ding, ding, ding. They proved, they showed that.
Yep.
So they should have taken the conclusion there and put that in the end of the paper. I would have been a lot happier. And I do agree, it's humorous that their results in their abstract is almost the same length as the results in the paper, but that's okay. Neither here nor there. Any final thoughts on this paper?
No, I think it was a great opening salvo for introducing a possible new line of therapy for high-risk physicians that deal with these kind of idiopathic findings, enabling us to possibly offer new therapies to women that are theoretically low risk, high reward. And I'd love to see how the literature evolves around this.
I agree. Now, and I want to go back and, I think both of us, but maybe me a little bit more, have given this paper kind of the rough treatment here. And I want to say that I applaud this group's work. I think that anytime you do any kind of study like this, it's hard, and it's years of work, and it's a lot of hard work, and so I really applaud the effort they put into this. I think we could have nipped and tucked a little bit, but I'm very happy that this was done and published, so that we can talk about it.
Agreed.
So I think we're going to conclude there. Now, this is the first time we've done this. I don't know how long. We didn't know how long this was going to be. I don't know how long the next one will be if we do it. I do hope that Dr. Ballas and I can get together and do this on a either monthly basis or semi-monthly basis, because I feel like there's real value in, one, looking at new papers and analyzing them for their own clinical benefit, but also just, you can take the kind of approach that we're using and apply it to any paper, so you know whether it's something that is valuable to you or not. And I think that there's so little of that out there for people to listen to or to interact with, that I hope that people really get something out of this maybe overly long discussion that we just had about this paper.
And there's something to be said about discussing these kind of works with somebody or even in a group. And I think that's what makes journal clubs so effective, because someone will pick up on something you didn't. So when Joe picked out the primary outcome discrepancy between what they stated and what they actually published, that was pretty eye-opening to me. So it's always great to kind of have different sets of eyes on the same data. You'd be amazed, absolutely amazed, the different conclusions that can come from things.
So with that, I'm going to say thank you very much to Dr. Ballas for joining me on this little odyssey we did here and embarking on a new project. Like I said, I hope that you'll be hearing from us again soon when we do this again. I am going to look to include some new people in this. So if you have an interest in clinical research or journal club type things and you want to be involved in this, please send me an email. You can find that feedback@obgyn.fm. You can join Dr. Ballas and myself and a few other brave folks on the Slack. It's a little quiet at the moment, but we had some interesting conversations about postpartum endometritis, and we'll be doing some new topics soon. So please, again, you can send the same to the same email, and I'll send you an invite. And this actually was a great paper. This was not really planned, but we talked a lot here about fetal assessment and fetal well-being, and that's actually going to be our next topic. So the next 3 episodes are going to be about antepartum fetal surveillance, intrauterine growth restriction, and again, this was not planned, folks. Dr. Ballas did not know this ahead of time, but the third one is going to be cholestasis.
Hey there. What a surprise.
There you go.
I like it.
And so those will be the next 3 episodes coming up, and then hopefully we'll be back again for another one of these journal clubs. Any final words there, Dr. Ballas?
No, this is a fantastic experience, and I'm hoping to see this grow, and I've gotten the word out to my maternal fetal medicine colleagues, and so hopefully we'll see a little bump in our Slack traffic.
There you go. All right. Well, everyone, thank you so much for listening. And so until next time.